So today we're going to discuss a range of equipment that we cover in ENT, which is the paediatric bronchoscopy set. Paediatric bronchoscopy is a procedure that, unless you are in a dedicated children's hospital, is an emergency procedure. In the normal DGH setting, it's perhaps done 1-2 times a year, usually in the middle of the night, and therefore quite a stressful situation. In a children's hospital, these are elective procedures and they are done for various conditions of the airway in the trachea and right and left main bronchus. The procedures range from foreign body retrieval to removal of benign papillomas and such procedures associated with that disease. In the district general hospital setting, paediatric bronchoscopy is a procedure that is mainly emergency. It is mainly for foreign body removal, done in children that have perhaps inhaled, pen top, safety pins, all sorts of things have happened. And we have the best range of equipment for tackling that particular problem. As I have mentioned already, the procedure is only done a few times a year, thankfully, but when it happens, it is a particularly stressful situation. These children usually come in some kind of respiratory distress, middle of the night, and you have a surgical team in the acute theatre there that isn't necessarily au fait with ENT procedures, and they are then confronted with a set of equipment that looks completely foreign to them because they haven't used it before or may have only used it a couple of times. When you are booking the paediatric bronchoscopy set from the demonstration department up in Dundee, this tray is what you'll receive. So you've got the top tray, which has the endoscopes, bridges, and a few forceps on. And then you have the bottom tray, which has got everything else in it. Now, this is one of the more complex sets within ENT. And the fact that it is used relatively infrequently doesn't help the situation for you and the customers that are involved with this equipment. So, the idea being, you need to show them how to assemble this set. You might be using our UK demonstration set as a reference set from which to do training on their own equipment. So you need to have this very well squared away in your own head, otherwise it won't come across very well. In order to do the training and make the training as effective as possible, basically you need to get all of this equipment out of the tray and lay it out. Now, with paediatric bronchoscopy, what you have to keep in your head to keep it straightforward for yourself is that the paediatric bronchoscopy tube is essentially going to replace the patient's endotracheal tube. So they are going to be breathing through this tube itself. So, even in our UK demo set, and especially in the customer's set, you're going to be met with a jumble of bronchoscopes like that. The most simple, straightforward way of sorting this out is to sort them into length order, and then there are various diameters associated. If you keep them all the same way around, it'll make things much simpler later on. So we have 30 centimetre length bronchoscope tubes in a range of diameters. We don't have all of the diameters here, this is just a selection of. We then have 26 centimetre bronch tubes here, and these are the ones for the little babies, which are actually 18 centimetres long. Now, as I say, this rigid bronchoscope tube has to replace the endotracheal tube, so the patient is going to be ventilated through this paediatric bronchoscope. You have these 4 ports here, and you have to seal them off with the various accessories that we have in the tray. This is where the problem occurs with the customer's sets, because they often lose the parts that go onto this part of the bronchoscope tube here. Very simple. This port attaches to the ventilator circuit from the anaesthetic machine. This port is for the prismatic light deflector. This is your working channel, so we have various different accessories to go on there. This port here these days is largely unused. This is a jet ventilation port, but you can imagine you're not going to jet ventilate down this if you have a patient with a foreign body that is loose or mobile in the airway, as you could push it further down into the lungs. To turn the rigid bronchoscope tube into the endotracheal tube effectively, you have to insert the prism here, and just to bear in mind this has two positions, number one position there and number two position all the way in. This port here is connected to the ventilator, so this has a plastic tubing connected. Your injection cannula there fits onto the jet vent port here, and you have two zeros on the bronchoscope tube itself and a zero on the jet ventilation cannula. Line those up and push till you hear the click. We are then left with the working channel, and as I said before, you have a glass window plug which fits in there, or you have the rubber telescope guide or instrument guide which fits on there, or you have the Fluvog adapter which fits in there, and then the Fluvog adapter has all three of those different accessory channels on it. These are just a push fit, so it's a machine fit, and to undo them you just give a twist and pull. So once we have assembled these accessories onto these ports of the rigid bronchoscope, the next part of the operation is to introduce the paediatric bronchoscope into the patient. Now, the best way of doing that these days is by attaching a telescope to the bronchoscope tube. And this is where we have another slightly complicating factor, because we have the three lengths of telescopes that we mentioned were on the set earlier. First of all, we can discount this one for now, because that is for the babies and they would ordinarily be taken straight to the children's hospital. I'll come back to that. We then have a 30 centimetre length telescope and a 36 centimetre length telescope. As you will have seen previously, we have 30 centimetre bronch tubes, 26 centimetre bronch tubes, and they are the two main lengths that are used. In order to keep the set as simple as possible, we do tend to make sure that the customers have the 36 centimetre telescope, and the 30 centimetre telescope is thus made largely redundant. So what happens now to attach the telescope to the bronch tubes? You have a 36 centimetre telescope, a 30 centimetre bronch tube and a 26 centimetre bronch tube. So we then have a selection of bridges to fix the telescope to the bronchoscope tube. Quite simply, 36 centimetre telescope, 30 centimetre bronch tube, you need the 6 centimetre bridge. These bridges are 10 centimetre, 6 centimetre, 4 centimetre, and then we have this little bridge here, which is for use with the 18 centimetre telescope and the 18 centimetre bronchoscope tube. So we now attach the bridge to the bronchoscope tube. This isn't actually that intuitive, but there are two knobs on the bridge here. You line those up with the cutout and a little groove on the head of the bronchoscope tube, and they are just a push fit. You then have the standard Storz locking mechanism there, and the simplest thing to do is to line those up and then line those lines up with the zero and the light post of the telescope. You then have a bronchoscope ready to introduce into the patient once the light lead is attached. Some people do attach the camera. Most people, in the situation that they're in, i.e. with a patient on the table in some respiratory distress, will get the light lead on there and they'll go straight in there. So that is then introduced into the patient. The next step of the operation is, once the bronchoscope tube is inside the patient and the foreign body has been visualized, the patient is now stable because you are ventilating that patient through the bronchoscope tube. So everyone breathes a sigh of relief in theatres, but you've got the foreign body to retrieve. Moving to the next stage of the procedure, once you have the paediatric bronchoscope into the patient's airway, you're ventilating, patient is stable, foreign body is visualised. The next step is to load the telescope onto the optical forceps. So, unlock the bridge and remove the telescope. Now, a common mistake or a common problem that occurs when the surgeon is removing the telescope is to flex it like that. You've got to point this out to the customers when you do your training, to be very careful and to let the scrub nurse or the sister know that if they see the surgeon bending the telescope like that, they should feel empowered to say, watch the telescope, stop. If they pop this telescope and break it during the procedure, there is a good chance there won't be a spare, and that is going to leave them in difficulty to remove the foreign body.